going to go over some of the tests, just a few, one or two tests that you do. And then obviously you'll do an MRI to confirm the tear, hey, before you go for an operation,
Yes.
or not.
So the real test is clinical.
Yeah.
So you'll take a good history and a good examination.
Okay.
The reason for the MRI scan is not only to confirm the diagnosis, but to see if there's any other injuries that goes with it.
Okay.
So whether you have articular cartilage damage, whether you have meniscal injuries, what is the extent of those, and check the other ligaments around. So when you get to surgery, you want to do a one-stop shop. You don't want to go in there and find, oops, you should have planned better surgery. So we're going to pretend that Taylor has ruptured her right ACL.
Okay.
Okay. So the two main tests is the Lachman Test. So all that you do is that you just secure the femur with one hand, so that you have control of the tibia with your other hand.
Okay.
And all that what you want to do is just bring it forward. Obviously, we're not going to get a positive test yet, but if she has an ACL rupture,
it will move.
The tibia will move forward. Yeah. Another a cheat way to do this test is called Tilly's test. So all that you do is you place your hand underneath it, just distal to the tibia tuberosity.
Yeah.
You can press down on the quad, and you'll see how the ACL hinges.
Yeah.
Now, if that doesn't happen, that means that the ACL is ruptured.
Okay.
The most commonly known test is to have the leg bent or the knee bent at 90 degrees. This is called the anterior draws test. Most important is always get the patient to relax. The hamstrings must be relaxed because that can obviously keep the tibia back.
Yeah.
You just gently pull forward. I like to keep my thumbs on the femoral condyle. You can feel how much translation there is.
Okay.
You can grade it as well.
This will be quite sore though, hey, for a patient, or not?
No, so in the acute phase, yes, it may be painful, but you often don't see these patients till about 2 weeks.
Alright.
So you can repeat that test.
Yes.
Around about 2 weeks after icing the knee and letting the knee settle down, it's actually completely painless.
So that's important, to get the knee to settle first before
Yeah.
you actually check it and then operate.
Yeah.
Okay.
Definitely don't want to operate too early.
Alright. And then obviously for when there's a meniscus, you showed us the test the other day, but just quickly show us again if there's a meniscus, and then for the MCL and LCL involvement as well.
Okay. So just a quick recap. So you've got medial joint line, lateral joint line, medial meniscus, lateral meniscus. So we'll just palpate the medial joint line. We'll palpate across here, check in the patient's face, and they'll tell you if they've got pain. You'll do the same thing on the lateral side. Besides the whole patient, yes. So I like the McMurray's test. This is how I do it. I bend the knee as far as I can go. I have my 2 fingers medial and lateral joint lines. So if we externally rotate, we check in the medial, and if we internally rotate, we check in the lateral meniscus.
Okay.
With the injury of the ACL, we can commonly get other injuries. So I usually palpate the medial femoral epicondyle, because this is, if you're going to get an MCL injury, this is the most common site that it hurts.
Okay.
Just run your fingers down gently along the length of the MCL to see if you get any injuries there. I also palpate the lateral femoral epicondyle and run my fingers down the length of the lateral collateral ligament to see if there's any pain in that area. The important thing is that you have to check it when it's fully extended, and you have to check it when the knee is bent at 20 degrees. The reason for that is when you have the knee fully straight, you're actually checking the structural integrity of the posterior capsule and not the actual ligament.
Okay.
Okay, when it's bent to 15-20 degrees, you're relaxing the posterior capsule, and that means that you're then really testing the medial and lateral collateral ligaments. Yeah. And all that you're feeling for is a good endpoint. Okay, the lateral collateral ligament always goes a bit more, but you're just feeling there. There's the endpoint, it won't go anymore.
Yeah.
And the medial side is the same.
Okay.
Compare both sides.
You want to show us the pivot shift test as
Yeah.
well. What is
So I want to show the pivot shift test. It's probably the most pathognomonic test. It's not always easily sort of induced in a patient because it is uncomfortable and a lot of patients do guard from it. But if you can get it out of a patient, it's pathognomonic. In other words, 100% guaranteed that's an ACL.
Okay.
So the way to do it, and a lot of people struggle with it, so you have to have the patient's leg nice and relaxed, okay? You have to find a way to get them relaxed and just promise them it's not going to be uncomfortable. So just don't tell them it's going to be uncomfortable. Okay.
But now they know.
Yes.
Watching this video.
No. So the idea with that is, so what you're trying to do is you're actually trying to sublux that tibia slightly anteriorly, because that's the rotational component of your ACL.
Okay.
So the way to do that is that you have to internally rotate the tibia. Okay. You have to apply a valgus stress and you have to then and internally rotate it. So now if you can use your mind's eye, what's happening in there is that with the rotation and the valgus stress, we're pushing that tibia anteriorly.
Okay.
And that's exactly what a pivot feels like. Now what happens with that is that you've got the ITB, it runs anteriorly to the middle of the joint. Now what happens when you bend it, when you flex it now, this is the whole crux of it, is that when you get to about 20-30 degrees, it's going to jump back into place. The tibia is going to jump back into place. And the reason why that happens is that because your RTB moment of force goes from anterior to posterior, so then it, because of its attachments to Gerdy's tubercle, is going to put it back into place.
Alright.
So that's the rotational component to the ACL.
Okay. So that's going to happen if the ACL is gone?
Yes.
Okay. Alright.
Like I said, and it only happens if the ACL is gone.
Okay. Dr. Bay, sometimes we get patients from you with a scar on the side of their leg, which is an EAT.
Okay.
And what is that? And why do you do that?
Okay, so the scar on the side of the knee is simply because we take a loop of RTB and we loop it around the lateral collateral ligament, and it's called an extra-articular anterolateral tenodesis, or otherwise abbreviated as an EAT.
EAT.
So the reason that we do that is that it's an old procedure. So before there were any sort of procedures to reconstruct the ACL, we used to do extra-articular stabilizing procedures.
Okay.
Our forefathers in orthopedics knew very well that the main problem with the ACL injury is the rotational component to it.
Yes.
So patients that are younger than 25 have a revision or have had an ACL on the other side will get an EAT from myself.
Okay.
And that's just to control that rotational component. We know that with time, your ACL, your reconstructed ACL, does get a little bit more lax, and patients do complain about problems with stability. So the pivot shift test, even though it may feel good in the beginning, returns and it causes them issues, and it may prevent them from playing sport and doing other activities again. So you can imagine that there's a loop of RTB from Gerdy's tubercle that's looped around the LCL like that. So if you've got a loop around the ACL like that, that's going to prevent that rotational component we're speaking about, and that will eliminate the pivot shift.
All right.
Yeah.
Thank you so much. Appreciate you coming through and sharing your knowledge.
It's a pleasure.
Okay.